All right. So we're just letting people in right now. This is the
Sorry,
June.
Pam, do you mind trying to promote people? I'm not the host.
Oh, geez. All right. I had the multiple on here. There's nothing listed on the side, Dan. Shoot, I should have had you do this. Okay. Where is it? The motion's on here, Dan. You don't know.
Sorry, the participants at the bottom.
Let's see
You
here.
click on that, and then they'll come up. Click on the attendees
Oh, it just says
at the
in.
top. Yeah,
Nope.
if you can right click on people and try to get them promoted.
Okay, here we go.
And also Christine Jason is in that list. So Christine, Mark, and Nate all need to be let in.
Let's see, Mark, here he is.
And Kathy also needs to be let in.
Yep, I just got her.
Great.
Yep.
Our compliance attorney was gonna phone in too, just in case we get into any 32B language. Russell Denver,
Okay.
if you want him on. You might see him in there. If you see Russell Denver, that's at EHUB.
Yeah, I've got him right here, Mark.
Oh, great. I don't think he'll be on video, but he'll be
Okay.
available for
That
questions.
does it. Look okay?
Yep.
All right. So I do not see Nate or Christine in the participants.
Okay, so Nate,
I see Nate on the
talk
screen.
about promoting him now. Okay. Mark, do you want Russell promoted to the panel or do you want him just to be allowed to talk?
I just allowed to talk, I would
Okay.
think.
All right, so that's all set.
Can you hear me
All
okay,
right.
Kristen?
Yes, we can. Yep. Thank you.
Okay. Thank you. Sorry, I used the wrong link, Pam.
That's
That was my
okay.
fault.
Oh, no. It's okay.
All right. And Christine Jason has been promoted.
She says she's
Jason.
declined to be promoted to a panelist. So Christine, let me try again. I'm going to promote and you can accept it. Okay, there we go. Okay, she's in.
All right, great. So 6 years later, we're still having Zoom challenges, which is totally okay. So welcome to the June 11th Health Insurance Trust meeting. We will all introduce ourselves because we do have a new member, Sean Kelly from the Select Board. I would like to note for the public and for the committee members, because this topic is one that has been widely watched, we will post the recording on the Health Insurance Trust website. That likely won't go up until tomorrow, but we are committed to do that before the weekend. So with that, I know we don't have official introductions on the agenda, and I think we kind of all know each other, but let's go around the room. So I'm Kristen Last. I'm the town manager. I serve as chair of this committee, and I'll pop that over to Hannah.
Hi, I'm Hannah Moeller. I am the tax collector treasurer.
Great. And then Nate.
I'm Nate McKinnon. I am the finance committee representative on the trust.
Pam.
Pam Hicks, Director of Human Resources.
Sean.
Hi, folks. Sean Kelly from the Select Board.
Great. We have Christine Jusum. She's saying that her microphone and camera may not be working, so I think she's trying to get that figured out. Christine, if you want to log on and log back off, but she is this union rep, and specifically school union. And then Jesse, if you want to introduce yourself and your role.
Yep, Jesse Beyer, town accountant, and I am an alternate on the trust.
And Dan.
Finance director and also an alternate to the trust.
Mark.
Mark Crisatelli from Hub International.
Great. And Kathy.
Kathy Breton from Hub International.
Great. And Hub International is our broker. I think many of us know that, but I just want to be clear because we do have some participants on the line that may not be aware of that. So first matter of business this afternoon is to review our health insurance trust fund balance. Dan, if you could take it away, please.
Sure. So May is our most recently completed month. As of the end of that month, we had $5,731,000. For comparison's sake, and that's the cash balance, not including the IBNR, the runout. Compared to last year in May, we were at 4.74 million. So we're definitely at a higher amount there by about $1 million. For June, we are projecting to close out the year with about $6.3 million. It's going to be a little bit inflated just because we have the school lump sum payment where the teachers and other workers who have their deductions taken in June for the entire summer will be put into the trust at that point, and that'll slowly work down a bit over the summer. So it's normal to do that, but just in case people see the trust fund declining over the summer, that's expected just with cash flow.
Great. Because we do have some new members who are watching, there was a question, and who is the retiree rep on the trust? There is no retiree rep. The health insurance trust is established under an agreement that was set forth by the select board in 2021, and all of the members on the trust are currently present online. If anybody's interested in reading the trust document that lays out the positions on the trust, that is on the health insurance trust website. So with that, Mark and Pam, if you want to give us a short overview of our claims utilization review, we haven't met in some time over this, so if we could get a brief update on that.
Sure. So I'll share my screen. I'll pull up the latest claims analysis. Please let me know if you can see my screen.
Not yet, but it looks like it's coming.
Okay, great.
There you go.
Excellent. Okay, so this is latest claim analysis, claims running from March 2023 through April 2026. Kind of a high level overview. So from our most latest.
Sorry, Mark, did you say 2023 through 2026?
Yeah, I think
it's 3 years.
There might be later in the presentation.
All right, so it's not just 1 year; it's a broader.
Yep.
Okay, thanks.
You're welcome. So in the latest year, our total claims paid were approximately 18 million, and that was from March 25 through February 26. Our pharmacy spend year over year, so comparing 1 year to the next, we went from 5.21 million to 5.85 million. Our large claimant list, this would be claimants that have claim totals over 50,000 in a most recent 12-month period. Their total was 6.3 million. Comparing to a previous period, we were at 8.9 million. And then our total paid claims on a per member per month basis versus benchmark. I know we use that word a lot. Benchmark in this instance would be Blue Cross Blue Shield's book of business. So comparing to the benchmark, our per member per month basis was 714 versus Blue Cross at 832. And a lot of things are taken in consideration there. You got different groups, different industries, different plan designs, but just overall on a claims per member per month, total medical and prescription, that's the comparison. Some of the key findings over the past 3 years this is really just totaling up the large claim category, so all claimants above 50,000. In March 23 through February 24, those people totaled 8.85 million. That decreased the next, it actually should be 24 to 25, and that was 6.27 million. And then May through April of this year, we're at 5.88 million total large claim total for people that had claims above 50,000. So those large claimants were a big driver a couple of years ago, and those have decreased quite a bit, which has been helpful. Again, our total paid claims were 714, which is about 14% below that Blue Cross Blue Shield benchmark cohort. GLP, we talked about it in the past. So the weight, and when I say GLP, I'm strictly talking about weight loss drugs, not the diabetes drugs. So in 2024, basically the 3 GLP drugs were Wegovy, Zepbound, Saxenda, total about 533,000 in 24. And then the most recent 12-month period, well, this is actually not quite recent because I know it's ticked up a little bit, but we were at 1.03 million, but roughly it doubled year over year. And if we looked at 23, it was probably half that 533,000. So it's quite a large increase. And this is not unique to Westford at all. This is every group, almost every group in the industry that had GLP-1 coverage. They're targeted to no longer be covered by Blue Cross Blue Shield in November. Because of that, we expect the reduction in our pharmacy spend to be about 1.2 to 1.4 million just from the GLP drugs. And our pharmacy on a per member per month base is actually higher than the benchmark cohort. So we're at 232, whereas the benchmark cohort is at 145. But that's really driven off of one drug. So we have one individual that's on a drug that's about $500,000 a year. In the past, it did not show up in the pharmacy. It showed up on the medical side. We had moved over to the pharmacy for the main reason that it saved the plan over $1 million by having the drug covered through the pharmacy benefit manager versus a delivery through the hospital where the individual was getting the drug. So that $500,000 drug really kind of skews our pharmacy on a per member per month basis. So I just thought that was worth mentioning. Well, this is kind of everything I just said, but more in colorful bars, if you like bars versus numbers. Just kind of shows our trending down over the years. And again, this period is supposed to be, no, actually, this is accurate. So these are our 3 years, and then we showed a more recent year. So March 25 through February 26, we were at 6.27 million with 56 large claimants. And then the most recent 12 months, May 25 through April 26, we're down to 50 claimants at about 5.88 million. So our biggest drivers over the past couple of years have been large claimants and the GLP-1 expenditures. This is, getting down into the nitty gritty, but we look into this. These are our large claimants by condition, by category, and then it shows whether it's medical and drug or prescription driven. So our largest claimants over this particular period of March through February, we had 2 individuals over $500,000. One was mostly prescription, and the other one was medical and prescription. That is driven, that's probably a cancer infusion medicine. So there is medicine being delivered probably in a hospital setting, hopefully not for long term, because a lot of the infused cancer medications, sometimes they're done in a year, sometimes 2 years, sometimes shorter, sometimes longer. But this is just a breakdown of our large claimants. And then you can kind of see in a category mix, totaling up, what categories are large claimants in. This is not unique to Westford, but the bulk is really, coming from cancer. And then RX driven is really number 2 from total percentage wise. I think cardiovascular and behavioral health come in at 3rd. And please, at any time, if anyone has questions, please ask. This breaks our claims down to 4 buckets, if you will. Facility, inpatient. So these are all inpatient charges, outpatient hospital charges, pharmacy, and then professional, which would be doctor visits, could be MRIs, CAT scans, anything that's not really, any type of surgery or inpatient. Comparing, year over year, we went from March of 2025 on a per member per month basis of $60 we went to $78. The benchmark, so our inpatient's quite a bit lower than the benchmark, but Blue Cross Blue Shield's benchmark went from 145 to 162. On the facility outpatient, we're quite a bit lower than the benchmark as well, and we actually had a decrease, 161 to 148, and Blue Cross's benchmark went from 223 to 255. On a pharmacy, we went up 204 to 232. Again, that's driven by that large claimant on that one medication. And then the Blue Cross Blue Shield's prescription went up year over year from 121 to 145. And then professional, we actually went down a little bit from 272 to 255. And Blue Cross Blue Shield went up from 245 to 268. So, I'm happy that we went down, but I think some of our numbers in the past were just inflated because we had a bad stretch, and things have gotten a lot better since then. Back to the GLP, and the reason why I'm just spending a lot of time on this is because of Blue Cross eliminating it from the formulary, as just about every other carrier and every plan has as well. Just kind of shows you how we trended. And this breaks down not only from the weight loss, but also diabetes. So you can see how many members were on these type of drugs over the past. So calendar year 2024, we were at 107. Then we went up to 136, and our expenditures went to 1.31 million. And then this is just the first 4 months of this year. We're at 0.51 million. So trend, if you trended that out, that's trending at about 1.53 million, if you were to just trend it out, assuming there were no increase in utilization there. This was just pulling out some of the diabetes and just showing specifically the Wegovy, Zepbound, and Saxenda. Saxenda's in yellow, so very few people using that. The top medications are the Zepbound and the Wegovy. So Wegovy is listed in red, Zepbound is listed in black. And again, not unique to Westford. A lot of groups have the same type of utilization patterns. It's really just a summary of that. So just, overall, I guess this is just summarizing everything. Our inpatients down, our outpatients down, our drugs are up. I think even without that large claimant, our drugs will probably still be up a little, but much more manageable. And then our high cost claimants are all down. So,
great. Thanks, Mark. I think we're going to get back to the recommendations a little later. So
sure.
Let's save that.
You bet.
Do the trust members have any questions on the utilization documents? And Mark, if you want to stop sharing your screen, that would be great.
Sure.
All right, so we'll move on. Dan, I just want you to give us an update on the budget to date for fiscal 26. We're entering fiscal 27 in a few weeks, and then any budget projections that we may be looking at just with the data and the knowledge that we have related to health insurance.
So the overall budget for FY27 is going up by 2.9%. That's a lot. We set the budget a year and a half in advance. So for FY26, we started that process back in September of 2024. And so at that time, we based the amounts off the current enrollment, and the enrollment dropped a bit over the next year or so. So the town did contribute some additional funds there because we transfer in 1/12 of the operating budget into the trust each month just for cash flow reasons. So that 2.9%, it's not that the rates went up 7% last November. But this is more of a correction to right size the budget for FY27. Looking forward, we haven't heard claims data yet on how we're projecting for FY28 on health insurance, but that discussion's coming soon. Budget wise, we are okay for FY27. We do have that health insurance budget set. And the way our health insurance runs is it starts on November 1st and runs until October 31st. So really we have a new rate coming in November 1st, and it'll run through those 12 months. So whatever, it helps to mitigate the impact from year to year, just based on the timing of that, which has been nice even before we had trust. So it helps to sort of offset any increase we have by a third budget wise. So, Chris, is there anything particularly you want to hear about?
No, I think that's fine. Do any trust members have any questions on budget to date or future? All right. So I think the meat of our conversation today is related to the locked-in presentations and then the select board recommendation that was given on Tuesday evening. So just for way of background, the trust hired Lockton in November of 2025 to perform an independent study of our current health insurance plan, our trust to identify the benchmarks we use those benchmarks in our classification and compensation as well, and then to look at options that we could explore for health insurance in the future. And there was a myriad of options and ideas presented. The Health Insurance Trust met with Lockton to hear the final report on March 31st. Then Lockton presented to the tri-boards on May 11th. We also presented to the IAC and PEC last week on June 3rd. And the school committee, finance committee, and select board have been having discussions. And I know, there's a little uneasiness of why this is happening, but health insurance was identified in the 2023 budget task force report as one of our highest cost drivers. And at that point in time, our health insurance was volatile due to high claims and the market at that time. We know that our situation has stabilized, but it's always good practice to discuss our options, especially when our trust is running well. So I don't think we need to go over the locked-in presentation or feedback from that unless anybody would like to. All of these meetings have been televised, and I believe that the majority of the people in the trust have reviewed that documentation. But before we move on to the select board recommendations, I just wanted to see if anybody on the trust wanted to add anything related to that.
Hi, it's Christine. I'm sure the same with you. I've been inundated with phone calls and emails from people. And it's very evident to me that there are the opinions I'm hearing some, some want to stick with Blue Cross Blue Shield. Some would love to have a less expensive plan. On a town level, is there going to be a survey to all employees, and for the employees specifically that have health insurance through Westford, is there going to be an opportunity to have a real simple survey to all the town employees before we come to a conclusion?
That certainly could be an option. I know we did a survey of employees. I know there's been some concerns that we did not survey retirees, and there's also been concerns that we've had some employee turnover since then. I think we as the trust need to determine what we'd like to present as recommendations to the select board. We may or may not want to do a survey for that, depending on what our recommendations are, but I don't think that it's off the table at this point in time. Yeah, Nate.
I think Christine's idea is a really good one to consider moving forward. And if we're going to do another survey, I also think it would be good to survey the people who are employees who do not enroll in our plan. Because this has been part of our conversation all along of, if you do things and change plans to either make them cheaper, more attractive, better benefits, how does that impact we have a relatively low enrollment rate in the plan. And so knowing their perspectives on that would be important information as well.
Yeah, absolutely. They were both employees on the plan and off the plan were surveyed back in September. So I don't see any need to change that. I think we would open it up to any employees or any retirees. So with that, Sean, I don't know if you want to lead this conversation or if you'd like me to. The select board met on Tuesday evening I know some of the trust members were in the audience and some may have watched the tape, but the select board has offered some suggestions for the trust to explore and bring back on June 23rd. Knowing that this is a lot of information and that there's a lot of data, my professional opinion is that we may have some things to bring back to the select board on the 23rd, but I don't think everything is going to be solved in the next 2 weeks. So, Sean, I'll let you tee that off based upon your role in the select board.
No, and I appreciate that. And I think Kristen did a fantastic job of capturing kind of where the select board is on this. And I know that this was said many times on Tuesday night's meeting and prior to that at the IAC meeting. No decisions have been made by the select board right now. We're trying to have a thoughtful process as to where the town's money are going. And everyone on this screen has been with our town for many years and knows that there's been some tough years behind us financially. And as Kristen pointed out, we have that budget task force report, which specifically identified healthcare costs as an area to review. So that brings us up to speed. After the meeting, right, and there was a great employee turnout, and I thank you to all of our employees who showed up. We value you. We care about you. We care about your input. So thanks for taking the time to join us on a Tuesday night. That said, I think the consensus of the board was pretty clear, and Kristen did a fantastic job of memorializing that into a memorandum, which has been presented to this trust. So if you hadn't had a chance to look at that, I would suggest that you do so. But I'll do my best to summarize it. And like Kristen said, this is an ongoing process. There are some dates associated with decisions that this trust has to make, right? But this idea that a decision is going to happen tomorrow, it's just not. And really, the select board wanted to hear from the trust before any decision was made. So hopefully we can have a fruitful conversation. So the things that they wanted, that the select board wanted the trust to look at, were first to develop a multiple cost saving scenarios, right? Healthcare is complicated. There are certain levers that you can pull. Employer contribution, co-pays, deductibles, stop loss insurance. I know I'm forgetting one, Kristen. There's the amount that's actually in the trust, right? So what the select board wanted to hear was not to come up with their own ideas, but to hear from you folks as to 3 areas that they think that the healthcare trust might be able to have some cost savings. And it's important to note too that one of the things that the Lockton report did was referred to us being above benchmark, right, in the plan that's currently being offered. And as we've done with contracts and unit negotiations, we generally, our target is benchmark, right? We never want to be below where our peer communities are. So that's something which brings us to the second point, which is benchmark Westford against other communities, right? And we regularly do this in the salary context. So we think that we should be doing it in the healthcare context too. So to look at other benchmark communities, what is the employer contribution? What is the employee contribution? Things of that nature. Third, regarding those scenarios, what impact it would have on employees and retirees. And I think that that's the big question mark that we're probably not going to be able to address tonight. And maybe some of that can be addressed through a survey and Hub might have to crunch some numbers on. But we want to see how, if we do make plan changes, right, how would that affect our employees, our retirees, and different cohorts, so our low, medium, and high users. And then lastly, to my knowledge, there's no written policy for this trust identifying what is in quote unquote adequate trust level, right? I think Dan pointed out $6.3 million currently. IBNR, I believe Dan quoted us at being around, Dan, 2 point something.
It'd probably be like 1,200,000 or so.
A million two. Okay. A million two. And then locked in throughout that, standard is 3 times the IBNR, right? So certainly that's much less than 6.3. So what we wanted to hear from you folks is like what does the trust think an adequate amount is? And maybe Hub can help fill in that gap with us. I know Locked In gave a suggestion of 3 times the IBNR, but so those are the 4 things that we'd like to consider and hear from you folks. And again, thanks for being here, and all the folks watching at home too.
Sean, just to add, the last
Yeah.
thing I think was the identification of potential funds available to offset costs, to either reduce future premiums or offset town costs or help address the broader budget pressures. Maybe you capture that in your overall words, but we know that this number of 950,000 is out there related to what the town infilled and the town meeting infilled into the trust a few years ago when we were running much more poorly. So just wanted to add that to the context for anyone who didn't have the memo in front of them. So this is a lot, right? It's a lot for us to chew on. It's a lot for us to discuss. It's a lot for this format. So we have given Hub the meeting video from Tuesday evening, and they were able to watch that. They did receive this memo. We have been in touch with them since we received the locked-in report, and they have been reviewing the locked-in report. So before we turn it over to Hub, I just wanted to turn it to the trust members of if anyone feels strongly making any comments or suggestions related to any of these 5 areas that the select board has given our direction. Yeah, Nate.
Thanks, Kristen. So just a question, I guess, and I was looking at your memo on this, evaluate appropriate trust level and identify potential funds available to offset costs. So, I mean, those two are related, but the thought is that we'll look at those sort of separate. Am I understanding that to be maybe the development of a formal policy on trust balance and having something in writing on that we can, at least use as guidance, if not stricter than guidance, and then a separate discussion on, once we set that, then the question is, okay, what's the excess? And the idea is whether or not we use that funds for that purpose, for the purposes listed in the memo. Is that kind of the thinking?
So I do believe that they're 2 distinct areas. The one is to look at a policy on our trust fund balance, and I don't think we'll solve that today, but we'll start that conversation today. And then I think the second is the identifying potential funds to offset our health insurance costs. They could be, from all other areas. Sean, I don't know if you want to add to that. Maybe I'm not being clear in my description.
No, I think you covered it. I understand what you're getting at, Nate. Are those two unreconcilable, right?
Yeah, I guess
Yeah.
I'm more thinking of we set a level. We seem to have a sense and we haven't discussed it yet, but it seems if we went with a 3, then we have excess money in there, and it is the goal of considering recommendations on how to use that, or what. But that's. I'm comfortable with just sort of exploring that with the group. I'm just trying to understand what we want to get to as an end goal.
Yeah, I mean, one of the things that I heard come up is like, okay, well, what are you gonna do for if there are any plan changes? How do you deal with the people who are impacted by this? And that's where I view number 5 coming in, is that there's an opportunity there to kind of help usher us along.
That's helpful. Thank you.
Yeah.
Jesse, did you have something to add to that or something different?
Hopefully something to add that will maybe help frame some of the conversations, because I think there was some confusion a couple nights ago too. So, and I think they are kind of the same issue, kind of different. The amount that we would potentially be talking about returning to, let's say, the town is capped at the 950,000. There's no extra that that can be returned. Now there's ways to reduce that balance through, say, lower budget increases, things like that. But we just have to be careful because the town and the employees, generally it's a 65-35 split. That's, I don't know the word statutory, I don't know if it's statutory, but that's the agreement that's contributed. So we can't, lower more than the supplement that the town made on special town meeting. So I think, it's a good question, Nate. Hopefully that helps. Like I guess like the way if we were looking about this, like with a budget concern or something like that, like 950 is what, if the trust wanted to, could be released to help the town.
Got it.
And then if we still thought as a trust that we wanted to reduce that balance, we could let Dan, model it, and Mark model out some budget scenarios where, I'm throwing this out, but Mark says a 10%. We say, no, let's do 8%, which helps Dan with the budget. I think
Okay.
that's maybe a good way to frame that.
And sorry, Jesse, if I can, Kristen, can I ask Jesse a follow-up? Thanks. So your point being that 950 was the town money that was approved as part of the supplemental emergency need at that town meeting. So only that would even be possible to go back.
Exactly.
I think the other part was ARPA money was the other part, right?
The ARPA is locked in. So Jesse, just one second. So
sorry.
Just for Nate and the public. So the ARPA money has to stay in the trust. It was specifically allocated for the trust, and we have promised the federal government that we're just using it for the trust. So that 400 some odd thousand cannot leave the trust, but it is helping with our balance.
Okay. Thank you. Hugely helpful.
Christine, did you have a question?
Yeah, I just had I was at both of the locked-in presentations, and there was a lot of information. Was my memory correct that we have more retirees that access health insurance through Westford compared to employees that are currently working?
I believe that's correct. Mark, do you have or Dan, do you have our data in front of you?
It's pretty close.
Yeah, it just exceeds it.
My recollection, it was in the 600s for the retirees and in the 500s for the current employees.
Okay. And has it been established who is now in charge of the retirees? I know there was a lot of going back and forth.
So are you meaning the retiree representative or on the IAC? So we put out a call for interested retirees on the IAC, and we set a deadline for June 23rd or 24th to get their volunteer activity forms for me, and then I'll evaluate that and get that filled as soon as possible.
Okay, great. Sean, thank you for recapping what the select board was interested in. It's comforting to hear that all over again, because it's hard to give a recommendation without having all of that data. So thank you for recapping that.
Dan, go ahead.
Yeah, just to follow up on Jesse's comments about the 950, that could be somewhat urgent just because of the audit requirements that we contribute at least 65% into the trust each year. So actually breaking that up over 2 years would be great. And since this is June, it could be a bit urgent to transfer something out of the trust and close out to the general fund for next year. And then, we could do the other portion in July or, whenever makes sense at the end of next year. So basically what would happen is we just wouldn't transfer money into the trust that's been budgeted during the year, and that money will close to free cash, which we can then just reserve on paper that could be used for any lawful purpose at a town meeting moving forward. But it is urgent if we do want to do that.
Kristen, I have the numbers if you want me to answer Christine's question.
Yeah, sure. And then I'll go back to, I have a comment on Dan's question. Sure. So go ahead, Mark.
So there's 607 on the MedX, so that would be 65 plus retirees that are on the MedX plan through Blue Cross Blue Shield. And then there's 631 actives and early retirees. So you do have some retirees that are on that plan. I don't have the breakdown as to of that 631, how many are retirees, but so it's pretty close.
I have it if you would like it.
Sure.
Okay. We have, we've got a total, wait, hold on, this is just gonna open. Let's see, retirees, we have 624, and for the actives, we have 530. And, oops.
Thank you.
No, wait, hold on, the spreadsheet, hold on one second. Actives here. Nope, I've got this wrong, I apologize. Let's see, actives, we have 530. Early retirees, we have 94. And so we have a total on the active plans of 624. And on the Medicare supplemental plans, we have a total of 629. So we just exceed the actives with the retiree headcount.
Is that, Pam, is that subscribers
Yes,
versus like members?
No,
Okay.
no, these are just subscribers.
Got it.
Right. So it's number of plans out there. It's not number of people taking advantage of the plan.
Yes, this nowhere represents the amount of people we actually have on these plans.
Great. So just to go back to Dan's final comment. So number one from the select board was develop multiple cost saving scenarios within the existing trust. Could be plan design changes, could be stop loss modifications, could be other operational structural changes, or could be any additional strategies the trust believes are appropriate. I want to get a temperature of the trust members of if this transfer of the $950,000, whether it be a lump sum or in 2 payments, is something that we would want to present back to the select board on the 23rd. And then I would not want to make the transfer until after that meeting, we got their feedback, and then we would have a subsequent health insurance trust meeting before July 1st. Is there anyone opposed to that? All right, I'm seeing head noddings. Nobody is opposed. So let's add that to one of our cost saving scenarios to present back to the select board. Say, okay, we're in consensus on one thing. That's excellent. Good start. I think the next thing I want to move to, and I don't think we're going to spend a ton of time talking about it because we don't know the numbers yet, is the stop loss modification. So as we all recall, we do have stop loss insurance as part of our plan for the high claimants, and we increased our stop loss last year from a deductible of $125,000 to $150,000. There was a recommendation in the locked-in report that based upon how we're currently running at the time of the report and with our benchmark communities, there may be an opportunity to increase that stop loss to 175 or 200,000. Knowing that we've only had half a year, not even half a year of data. I think we've had two and a half months of data on that new stop loss, correct? Because we started in March of 2026. I just want to have a general conversation around stop loss and that modification. Mark, I'll ask you to chime in on this based upon how we were running in the past, how we're running now. And I also would love your opinion on, if we were to increase further, likely we probably could not reduce again based upon those claims. So if you could just give a few comments on that.
Yep. So I certainly can run some analysis to show you, what the expected cost savings would be or lack of cost savings if you increase that deductible. It very well could be, especially if large claimant activity goes down or continues to go down as it has the past 3 years. So I can run that analysis for you. And then also, I think it would probably be worthwhile to see what the average specific deductible is for cities and towns of your size. Maybe not just cities and towns, but all employers of your size to look at that. And then we'll just run some analysis and show you reports on that too. And I'm sorry, Chris, what was the other thing you wanted me to talk about?
I think just based upon that that generally it is difficult to move the stop loss deductible down, correct?
Yeah.
After we've gone up.
It's very difficult. Once you go up in your specific deductible, it's very difficult to get it reduced. The reason being, and this is not exactly a scientific method, but when you let's just hypothetically say we went up to a $200,000 deductible. And the next year we said, well, we would be more comfortable with a $175,000 deductible. So you go out to the marketplace, and the marketplace says, all right, well, we've got all the claim reports to do an analysis, and we can come up with a premium. Underwriters are suspicious in nature, so they think you know something about your group that they don't know. So if you're lowering your deductible, they're thinking you're going to have more than your fair share of claimants above 175, and typically the rating of it is just not advantageous for the group. So it's I've been in the business for 37 years. I don't think I've had a group that's reduced their specific deductible that I can recall. Maybe in the under 100 life segment, a very small group, you can have a little room up and down there, moving from 65,000 to 70 or 70 back down to 65, but not for groups of your size.
Great. Jesse, I'll get to you in 1 second. The other thing I think we should explore is we're currently off cycle in our stop loss because our trust started in March and our renewal is in November. We've had plenty of these conversations, and at the point in time where we've had the proposals in front of us, I don't believe that our trust was at a position that we could make that adjustment. But I think we should still continue to have that on the table related to the stop loss. Jesse, go ahead.
Mark, do you have any thoughts? I'm just kind of curious. Towns, when do they look at raising their stop loss? When, they're facing a huge stop loss premium increase? Is that like basically their force, or when, like, is there,
good question,
you can also
Jesse.
leave too much money on the table by not having it high enough too.
Yeah. Sometimes you get caught chasing. Some groups will get caught chasing their tail, trying to overthink it and thinking they can see into the future. So we have groups that will look at a very high deductible when things are running fantastic, right? So they just don't have anybody exceeding the specific deductible. Great, let's raise it. We'll lower the premium. We don't have to worry about it because nobody gets up to that level. So we have that group or that philosophy, and then we have the other. We've gotten 2 years in a row where we have 35% rate increases. We need to increase our deductible to help reduce the premium. And then there's a third option. There's some that will say, well, we're going to raise the deductible on these 3 bad risks or these 1 or 2 bad risks. So you have a $150,000 deductible for everybody, but Billy and Mary, who both have some, dread disease where they're taking a medicine that's $900,000 a year, the carrier will what they call laser them and put a higher deductible on them. Okay. Sometimes carriers, if you don't have that provision or that protection in your contract, a carrier might do that upon renewal. They may say, here's your renewal, but Billy and Mary have a higher deductible. So we actually put that provision in your stop loss contract where the carrier cannot do that. But we've had alternatively, sometimes if you get a bad renewal, the carrier will allow us to put a higher deductible on someone. We may know Billy or Mary, they're leaving the plan or they're going on Medicare. We don't have to worry about them as a risk. We don't go ahead, put an $800,000 deductible. We want a better renewal. So we kind of, use the knowledge to take advantage of the situation and get the lowest possible cost. So we have done that in unique circumstances as well.
Great. So I think related to stop loss modifications, what I'm hearing that we could report to the select board is that we are just in the first few months of our current cycle, and that we would be committed to reviewing this in the next cycle related to both the deductible and changing the term. Is there anything else that I'm missing that we should potentially be talking to the select board about related to stop loss?
Hey, Kristen.
Yes.
I just have a question. And I guess this is directed to Mark. Mark, if my understanding with stop loss is that if you raise the amount, right, it would equate to lower premiums.
Correct.
And are we? I guess I'm a little confused about that because what you just suggested is that that's not the case. So let's say that right now, I believe our stop loss is 200,000. Is that right?
175.
175. Okay. Let's say we upped it to
No, one.
No, it's
250.
150.
or
One,
200.
I'm sorry,
150.
Pam, we're at 150, sorry.
We're at
We're at
150.
150. Okay.
We kept it there.
We raised it to 200,000.
Yep.
Are you saying that will not necessarily equate to town saving? I understand it increases our risk, but I'm just
Yep.
saying from a purely premium standpoint, will that equate to lower
Purely
premiums?
premium reduces in that instance. Absolutely. So what we do, Sean, typically is we'll look at all the medical conditions going on before we make that decision. And then, we have tools to determine how many people are going to exceed that level. So I'll just make up an example. Let's say we're at 150 now. We're going to go up to 200,000 a deductible, and we're going to save 190,000 in premium to do that. Okay. If we have 4 people who reach the 200,000, we've just taken on $200,000 in extra claims, right? So in that case, it wouldn't be worth it. So
Right.
At the time, we try to make that decision. Are we going to have 4 people reach 200 or not? If we don't think we will in this particular example, if we're very confident we're not going to, of course, none of us know what lies ahead tomorrow. But looking at the past, if it looks like a good bet, that we say, yeah, do it. Go ahead and make that bet. And save the 190,000 in premium, because we're only going to have 2 people go above 200. So we're going to lose 100,000 in extra claims that we have to pay, 50,000 per person, but net we save $90,000. So that's something we do every year. And usually, sometimes it's just like getting an auto insurance deductible. Should you have gone with the $2,000 deductible or the $1,000?
Sure. Yeah.
If you have a 16-year-old driver, you go with the 1,000.
I mean, all insurance is risk-based, right? I mean,
Yes.
It's collective risk sharing.
Yep.
Sharing. So I guess that's my point. Is I wouldn't completely take it off the table, especially if it's a lever of reducing premiums on the employee side, because the employee will benefit from this if they're paying less. Because if the town's paying less total into this, then the employee is going to pay less total into it too. So I would suggest that we just keep it on the table, but of course we'll continue.
Kristen, it may be helpful. I find every year the document that Mark puts together for us on stop loss that has the net impact based on our current claims very helpful, because it lists out different scenarios of changing the deductible and what the assumed new risk will be taken on. And we just did it back in February, I think. So it might be helpful, since Sean wasn't on the trust, that it might be helpful, Kristen, to share that document, because it's a really nice visual to be able to understand how it impacts based on our actual claims.
Great. Yes, I can sit down with Sean and go through it, or hook him up with Mark to look at it. So I think we have consensus on continuing to look at stop loss based upon how we're running and the health of the trust fund. Staying with item 1, related to any other operational or structural changes or any other additional strategies or any plan design changes. I know that opens up the can of worms, right? But we need to look at this. We need to talk about this. So before I turn it over to Hub, does anybody have anything more detailed that they want to add to this category or talk about in this category? I do think Hub has run some scenarios based upon the locked-in report, as well as what they heard from the select board on Tuesday night. But before I turn it over to Mark, is there anybody else who wants to weigh in on this before we move forward?
Oops, sorry.
Yep, Pam.
I guess I just wanted to add that, or talk about the GLP-1s we've touched on, and the 950,000. The GLP-1s, when it comes to our plan, are providing relief. Right now, we're on track for, I believe it's $1.3 million. Going in the year ahead, we'd be over 1.5 million. So right now, if we were doing the renewal, we'd be looking at about $750,000 of savings to the plan. And then if the 950,000 was taken out of the trust, the health insurance trust at this point is actually providing a tremendous amount of relief to the budget as is. And I just want to be sure that with that in mind, when we talk about the plan design changes, that because we are self-insured, we do not get the same value as we would if we were fully insured for we used to call them decrements. So if you made a certain plan design change, you received a percentage change for that. Now, because we just pay the bill, we're looking at the value of transferring what the plan paid over to coming out of the employees' pockets. And so it's really understanding, and Mark will, help walk us through all of this, but really understanding that when we say plan design changes at this point, that we're not going to realize the savings that people think we are. And it's really trying to understand what it means to employees for out-of-pocket costs and what it really is going to provide for relief to the plan at this point. And also keeping in mind that this year, the plan is providing so much relief to the budget. And another, it really is a big deal to hold on to plan design changes until you need them. It's even like the stop loss deductible. If you don't need them, you are running well. Those aren't the years to kind of cash in those levers or those chips, because when you are running rough, you need those. And if you take them away now, we're not going to be in position to make changes later on. So I just wanted to add that for some context, because it's when we look at our health insurance and we look at like the contribution for the town at that 65%, yes, it is 19th not out of 20 communities. We are at the bottom. But that 65% actually protects the plan, it protects the employees who take the insurance, and it protects the plan, the budget and the plan itself, because it's helping to contain costs. And so it does a lot of really, I know the people get upset about the contribution level, but it actually has really helped to give the town the ability to maintain what we have. But I just want to put some context to, before going and talking about other things, and that right now we are running tremendously well. We have not run this well in a long time. And I just wanted to, say that.
Thanks for that context, Pam. I think some of the comments I heard get to number 3 in the select board's memo of show the impacts on employees and retirees. So we'll make sure that when we're running these scenarios, we will have those impacts as well. Nate, did you want to add something?
Yes, thanks, Kristen. I think our plan is running well. And what Lockton told us in that report is it's a lot of money and it's expensive. And that's, I think, unfortunately, part of the reason we're only contributing 65% when a lot of other clearly communities are doing better by their employees in terms of a percentage of the cost. And at the same time, doing well within the confines of the health insurance trust has to be taken into account. And this is what the select board has asked us to do with the context of the entire town's fiscal state, and that our increases year after year are outpacing overall revenue increases year after year, even though we did a bit better this year and hopefully can maintain that in our health insurance rate setting. We are still one of the largest cost drivers in town. And much like the select board made the very difficult decision for another cost driver, which was trash and waste removal, of having to come up with cost sharing with the residents of the town in order to ensure that doesn't become a runaway cost driver that we can't ultimately contain from a fiscal perspective. I think it's really important that we do look at plan design changes. One of the things that the Lockton consultant told us was that we risk having a very attractive plan being far more attractive from a benefits level for people who might not be on it right now, and having people steered towards it because it's so generous as a plan. I don't want us to do anything that at the end of the day harms our employees any more than we want to do anything that harms any resident in town. And we need to take all of that into consideration. But the select board has asked us to consider plan design changes. And, as part of that, I think, when you make plan design changes, I agree with what Pam said. It can be a cost shift, and that is unfortunate. But we need to understand the impact of what those are and whether there's the potential to figure out how we can do that in a way that's best for the employees who are members of the plan, as well as the town and our bottom line, and trying to thread a very fine needle. And so I just want to make sure we can we can keep that in mind as we move forward.
Yeah, Pam, go ahead, and then I'm going to turn it over to Mark.
Yeah, no, I just wanted to put in one little qualifier from Lockton, was that when he said that our plan was, very robust for the benefit level, and he was concerned about people coming on the plan. He also said that our premiums are not rising as fast as other communities. So the worry was that our premiums are actually going to be less than other communities and our benefit levels much higher. So I just wanted to clarify that. That was all.
So Mark, based upon the information that you've heard today and that we've fed you over the past few days from the select board meeting, as well as the Lockton report, do you have a few items that you can share with us to consider today? And then I know we need to run additional analysis, and I'm comfortable working with Sean to let the select board know that we might need to run additional analysis, but we do know that there are certain deadlines that the decisions have not been made. So I want to hear from you first, and then I'd love to hear from Sean related to, the next steps in the process.
Sure. So we did run a lot of analysis on the various options that you had discussed, frankly, prior, or I guess during this whole process, even before the meeting you had on Tuesday night. So we looked at several scenarios of changing the plan design. Our target was to make the plan design changes consistent with kind of the average of the market basket benchmark group, and also the GIC plan. And there's some little variances in between each of those plans out there, those market basket groups. Some of them have higher deductibles than others, but from an actuarial standpoint, they're all pretty consistent with the GIC plan. So we did target the plan changes off of that. So in scenario 5, can you see my screen okay?
Yes.
Okay. So scenario 5 is simply saying we're going to do plan changes. So we're going to take our current plans as they are today, make plan changes that are consistent with those of the GIC and those market basket groups. And we would we would expect the cost to be somewhere around $18.39 million for that. And again, our starting point, frankly, is we're looking at FY27. So I simply took current working rates today, and for FY27, I use an assumption of a plus 5%. I know we haven't set the rates for FY27 if we weren't to do plan changes, but using the data we have today, our starting point is 19.97. So if we simply did plan changes remaining with Blue Cross Blue Shield, we would expect to see a total savings of about $1.179 million. We added to the cost the mitigation amount, that 25% mitigation amount, that if you were to do plan changes, my understanding is through 32B, there would be a mitigation process, and you'd have to share a portion of those savings. And I believe that's 25%. And I'm not sure if you guys have adopted Section 19 or 21 through 23 of 32B yet, but if you do go through that process, you'd have to have one of those adopted. The next scenario is saying we're going to take your current plans, we're going to make plan changes to them, again, just as we did in the first scenario, or scenario 5 in this instance, and we're going to add another plan in there. That other plan, this is, we've talked about a little bit in the past. This would be offering another plan design, another TPA next to your current plans. It's a reference-based pricing plan. Again, only one other municipality has done this and gone down this road. This is a city of Chicopee did it. They're going into their 3rd year. The state's actually talking about it. They've begun those discussions in their past couple of meetings. I don't know how long it would take them to go there, but basically that would be another plan option that you would offer next to your current plan options. We made an assumption of enrollment migration to that plan, and then our expectation would be that the annual cost would be about $17.8 million. Because of the additional savings, there's additional mitigation. So we'd be net $18.356 million, which would be about a $1.6 million savings. And then lastly, we talked about doing those same plan changes with the Blue Cross Blue Shield plans. And beefing up your HSA plan and methodology, making it a little more attractive for employees by funding part of that deductible, half of the deductible on the HSA. And then we made some assumptions there as to migration of enrollment onto that plan. And that would get us to about a $17 million savings. We had, because of the additional savings, we would have additional mitigation funds that would have to be shared. And I also added in the value of the HSA contributions for funding half of that deductible for the employees that enroll in that plan. So in that instance, we would end up at about a net 18 million or 1.955 million savings. I will caution you on the HSA alternative, which I'm on an HSA. I actually, most employees at Hub are, but Hub's a little different. The insurance company is a little different than the cities and towns, municipalities. But what typically happens when you make up that HSA and you make it attractive, you have to be careful with the pricing differential, because if it gets too attractive or it's discounted too much, a lot of times what happens is your healthiest people migrate over to that. If they don't have claims anyway, all that's happening there is we're not really saving money on them. We're just collecting less money from them on premium contributions. I'm going to pause because Nate has his hands up.
Thank you, Mark.
Sure.
And just a couple things. First of all, please don't take this personally, but I've had you do this before. But if you could just, for the purposes of the record, just confirm that as our broker, if we were to go to a group purchasing arrangement like the GIC or Maya, you would be out of you would lose our book of business. If you don't mind just confirming. Thank you.
Yeah, absolutely. Yeah,
okay,
if we don't, yeah, you can.
No,
there are groups that have hired us that can go to the GIC, but we wouldn't be your broker anymore.
Correct. Yeah, I just think that's important for the purposes of the public record and for full disclosure. So thank you.
Yep.
My question to you is, if you scroll back down, scenario 7, an HSA. To have an HSA, we would be required to have a high deductible health plan.
Yes.
Right. So that means that if I remember correctly, I think the minimum individual deductible will be $1,700, and the family $3,400 at a minimum, right?
Correct.
Okay. All right. So I just want to make sure that as we're talking about this, that's in the back of our mind of potentially biggest savings. And part of that is because it's a very big deductible. You have to have a high deductible.
Yeah, and your cost shifting to the employees that go on.
Yeah.
Right.
And below that, you can still have an FSA, like a flexible spending account where you use or lose the money.
If you have an HSA compliant plan, you wouldn't have an FSA tied to it.
Right. But if you have a lower deductible plan, you can do an FSA.
Absolutely.
Yeah. That's I think it's important that we all just think of that in mind, of the differences between that, because HSAs can sound very attractive, but they do require substantially higher deductibles. So thank you.
You're welcome.
So I see some other hands. Before I will definitely take them, so I want to have any questions related to scenario 5, 6, and 7, and maybe there's more scenarios that we talk about today. Mark, I also want you to talk about scenario 1, 2, and 3, because there is some difference related to what the Lockton report had and what you have. So, but before we go there, I'll do Christine first and then Sean.
Okay, thank you. How many people are currently using the GLP-1 on our current health plan?
I can estimate, Kathy, if you could jump into the file, maybe you could see.
I'm in the file now.
Yeah, there's a GLP claim.
So we have 2025. We don't have 2026 numbers, but 2025 we have 126 claimants between Saxenda, Wegovy, and Zepbound.
And does it differentiate between which are using it for diabetes versus?
So it does. So diabetes is Mounjaro, Ozempic, different medications. So Saxenda, Wegovy, and Zepbound are only for weight loss.
Okay.
So it's the full 126 people on the weight loss.
Okay. Thank you.
John?
Yeah, thanks, Mark. Mark, I was wondering, I don't know if you were going to get to this, but if you can talk briefly about what those plan design changes are in scenario 5 and 6.
You want me to get into what the deductibles and copays are?
Yeah, really what the difference is. So if you could tell me what the deductibles and copays are now, and then what they would result in.
So currently, your most enrolled plan does not have a deductible. So these plans are all, I believe, set at a $400 deductible. That deductible does not apply to all services. It applies to hospital, surgical, some MRIs. It does not apply to primary care visits, certainly does not apply for routine physicals, and does not apply to specialist doctor visits. There's a separate deductible of $100. So currently this plan has no deductible on prescription drug. These assumptions are there's a $100 deductible on prescription drugs, as well, a separate $100 deductible on prescription drugs. And then the other difference is right now we have what I'll call an open network. So you can go to whatever hospitals you want. You don't have to pay a higher or doctors you want. You don't have to pay a higher copay or higher deductible. Higher surgery copay or inpatient hospital copay. The benchmark plans and the ones I'm showing with the plan changes have different deductible levels depending on what providers you use. So if you use some specialists, you might have a $25 copay. If you use a certain group of specialists, you might have a $40 copay or $50 copay. And then hospitals, if you're getting the colonoscopy, for instance, at a local surgical center, not tied to Mass General or Brigham Women's, you pay a lower copay. If you go to those facilities, you might pay a higher copay on top of that, a $250 or $500 copay.
Sorry, can I follow up, Kristen?
Yeah,
of course.
Okay, thank you. So in a situation like scenario 5 and 6, right? We would be asking the employee to share some of that burden through a deductible or a copay. Would their overall premium, so the 35% that they currently pay, would that number go down under scenario 5 and 6?
Yeah, the 35% would hold true, but the working rates that the 35% is based off of would go down.
Right. So essentially we would be shifting, we'd be taking the weekly amount that's taken out of their paycheck each month would go down, but their copays and deductibles, if they use the insurance, would go up under scenario 5 and 6. Is that right?
Correct.
Okay, thank you.
And just side note, Kristen had charged me with coming up with different scenarios. So we're gonna come up with a list of many different scenarios for people to show what their expected out-of-pocket costs would be on the plan designs I'm proposing here versus what you have now. So you can actually quantify what their out-of-pocket, what their expected annual out-of-pocket increase would be, not from a premium standpoint, but from a copay and deductible standpoint.
Great. Thank you. That was something that the board was very interested in seeing. Before we move on to scenarios 1 through 3, Pam, did you have a question or comment?
Yeah, I just wanted to comment that on the scenarios 5, 6, and 7, that that includes the GLP-1 coming off. So that is not just from the plan design changes. So I think going forward, it would be important for Mark to flush out what is the GLP-1 and what would be the plan design changes, because it looks, the GLP-1s is such a huge component of that. I just want to make sure that that is taken into consideration. And just make sure we're accounting for that on the spreadsheets. And then the other thing was, let's see, that one. Actually, that's right. I'll pass for now. Sorry.
Okay. Mark, if you can go ahead and explain scenarios 1, 2, and 3, and then we can just have an overall conversation of the scenarios and how we want to proceed next.
Okay, great. So scenario 1 is if we don't do a thing, we don't make any change, and I'm approximating a 5% increase effective this November. Again, it's a placeholder. Please don't hold me to that right now. But if we did that, we'd be at 19.97 million. Okay, for total. That's not just the town's contribution. That's the employee's contribution as well. Scenario 2 is assuming we leave Blue Cross Blue Shield, we go to the GIC. These rates are based on effective July of 2026. So we know that your plan renews in November, and they're going to have a rate change next July as well. These don't take into account that. So this is just assuming 12 months of these rates. So from July of 26 through June of 27. So this Mix A makes some assumptions that we have heavy enrollment in the WellPoint Plus plan. And we were at a 16.6 million, which would be substantial savings that first year going to the GIC, just premium to premium. Other costs we'd have to take into consideration, we would have run out costs. So hypothetically, if we left Blue Cross Blue Shield and went to GIC effective July, we would estimate you'd have about 3.986 million of run out costs. We would also have a mitigation payout of approximately 836,000. That would be total first year of about 21.447 million, compared to renewing and not doing anything, and you're at 19.9 million. That's year one. Year 2 and 3, if the GIC has good renewals, you're going to have savings year 2 and 3. So this is really comparing year 1. And I'll get back to talking about year 2 and 3 in a moment. Scenario 2 is changing the mix a little. Scenario 3 is changing the mix a little. This is having a little more people go to the Harvard Explorer plan, which is one of, if not the most enrolled plan at the GIC. They're kind of neck and neck, WellPoint Plus and the Harvard Explorer. So this is making assumption that we're going to have a little more enrollment into the Harvard Explorer plan. Reason why I showed another scenario is we don't know what the buyers are going to think. Massachusetts buyers, Harvard's kind of a household name. People have a comfort level with it. They might have had it in the past, job or through a spouse or elsewhere. So, we made an assumption that we had more people going to the Harvard plan. If that was the case, we'd be at 17.368 million. And again, 3.986 million run out, little less mitigation because we're not saving as much up front. Of 650,000, and that would be a total first year plan cost of 22 million, or about 2 million deficit. Now, of course, if we had the 3.986 million run out, we still have money left in the trust if we're running the way we are right now, based on the projections Dan gave earlier. Now, one thing, so speaking of year 2 and 3, again, this is just year 1. We don't know what the GIC's renewal is going to be in July. I can tell you the past 3 renewals, I know that they've set their rates too low, and that includes this renewal. I think we've talked about it in the past, over the past couple of years. Last year, they were short about 240 million. They were underfunded, that they went to the state to fund to bail them out. Otherwise, they couldn't pay claims anymore. And then this past, I think that was May. That was May of 25. And then April of 24, they had to get an additional funding of 300 million based on how they're setting their rates. So I'm pretty confident that they've set their rates too low again. This year, I would bet that sometime in late winter, early spring, they're going to need another chunk of money so they can continue to pay the claims on their plan. I don't know what that would mean for the renewal next year. I don't know how long they can continue that. I think that might be one of the reasons they're starting the discussions of a reference-based pricing plan, maybe adding that to their menu of plans. But I think they've gotten to the point over the years that they just keep increasing their deficit, that I would count on a higher than usual renewal next year. I think they avoided a little bit this year because they made the decision to eliminate the GLP-1s for weight loss. That was about $49 million savings, as I recall. So I still think they're too aggressive with their rates. So year 2 and 3, I would bank on higher rate increases.
And Mark, once you plan design changes as well, because the governor had said no to them at this point because of the response from those who are enrolled in the plans. So it's probably they're going to be seeing those significant plan design changes that are on the plate.
They'll have to do something eventually. But I don't know. Maybe they can keep, for all I know, maybe they can keep running at a couple $100 million deficit every year. I don't know. That's above my pay grade.
Thanks, Mark. Does anybody have any questions on that? Okay. So, Sean, as your select board role, and I know we've already lost Nate on this meeting, and I know, I don't want this to go past 5 if we don't have to, and others may have other commitments. Based upon what we've talked about so far, we are not going to be able to deliver everything in this memo by June 23rd. There's definitely some more analysis that we need to do and some more outreach that we need to do. I think we've agreed on what we can deliver is related to the 950,000, committing to looking at stop loss, looking at these scenarios more. Just from your perspective as a select board member and not speaking on behalf of the select board, what else would you like as for us as a trust to review and discuss today?
No, I think, again, speaking on behalf of myself, but I think many of my colleagues would agree too. The thing that we need to know is what, if we do go a route that has plan changes, how will this affect our employees, right? I think this select board has been clear and consistent that retention is a very important thing that we care about. We value our staff and we want them to stay. And we certainly don't want anyone to leave because there's a plan design change. At the same token, there's some opportunity here. And there are things that are referenced in the locked-in report that suggests that there's opportunity. So are there ways that we can make this work for everyone, that everyone's in agreement to? It sounds like we need more time for that, right? And I concur, Kristen. I don't think that we'll have specific plan design changes by the 23rd. I'm happy to hear about the transfer of the 950,000. I think that's a start. Eventually, this trust is going to have to come up with a policy that we can follow, so it's not a guess how much money is in the trust, right? So I think that's something that we have to revisit. But the things that I would like to see going into the 23rd are what impact would these proposed changes have on the employee level and the retiree level, the user level, right? And net savings are great, but if it puts too much of a burden on the employee, it's not great. So if we can have some more information on that, and I know, Mark, you touched on that a little bit about deductibles and the like, and maybe we could talk about comparing the deductibles versus the employee payment of the premium, so that I think that information would be most helpful to us. And does any of that change for high users, middle users, and low users, right? And I don't think so, but does that change from retiree to, whatever we're calling them, active employees? So those types of things I think would be very helpful. But I appreciate the analysis and I appreciate having some options. And one thing, Kristen, I don't know if we're wrapping up. If I could hear from this trust, if there's any of the options that were presented that someone is looking at and is saying, absolutely, I can't stomach that. That is just too far. I would like to know that now. It seems like option 7 is the most, how should I characterize it, Mark? The most, it puts a heavier burden on the employee because it's a high deductible, right? So if people cannot palate that, I would like that information, right? So
yeah, I think definitely want to hear from all the trust members, and then there are several items in the question and answers, and I think there are some people listening, so I don't want to leave the meeting without helping to try to answer some of those questions as well. So I'd love to hear from the trust members related to the options and next steps for the select board, and then we'll give an opportunity to answer these questions that are coming in, and anyone who has a question or a comment to speak. And then definitely want to take the time to set a next meeting date while we're all here together, because there are a lot of things to review at this point in time. So Christine, I think you said you I thought I saw your hand
Yep.
raised.
Yep. Mark, thank you for going over that so clearly. And again, Sean, thank you for saying exactly what I feel. I want to know how it would affect everybody. In some of the plans, I know one of them, Chicopee is doing it. We in Westford need to think what is best for Westford.
Yeah.
And, I want people to think about how many whatever design plan changes, I would be curious how many towns have those such plans, how many, what towns. I had one more thing. And I know it's in Lockton's report, I believe, or I know I heard. I think it's always important to think about, out of all the different municipalities, how many are going with the GIC, knowing how far upside down they are. Thanks.
Anyone else on the trust want to say anything before we move on? Yeah, Pam.
I know I'm struggling speaking online today. I apologize. I guess for the big picture for all of this, and I know I probably sound like a broken record, Kristen. But when we look at, we're self-insured, and so we have these claims that we have to pay. And what I struggle with is when we talk about plan design changes and cost shifting to employees, we still have an issue of having to fund our claims. So when we talk about high deductibles and whatnot, we're changing the method in which employees are contributing dollars to this pot of money to be able to pay our claims. So it sounds great to say we're going to put a high deductible in and whatnot, but the cost shift to the employees, it may not work, because the people who aren't using the plan are not going to be contributing those dollars. And so if you take their premiums out of putting them into the one pot, and we have this combined pot of money that everyone is, putting into, and then you reduce that, then you're reducing the amount of money coming in to pay your claims. So then you're going to have to raise your premiums to be able to pay the claims. And at the same time, if you were to reduce the claims, or reduce our premiums substantially, or even a little, you run the risk of migration. So what could happen, because we only insure 56% of those are currently eligible for benefits. That is about 10% less than a normal municipality. And so if we had that type of a swing, or even a partial swing, you have now undone any good, or what was thought of trying to find money in the budget to do something else with. You have now created a problem where you've got a pool of employees that are now having significant out-of-pocket costs. Their premiums have been raised because you still have to pay your claims. And we've got more people in the plan, and we've blown up the budget. And so it is this very, very serious balancing act. And that's why I'm always talking about the 65%. It protects the plan, it protects the town, and it protects the plan itself. And we have chased every dollar for 2 decades. We've changed plans. We've chased every penny, and we've done that to preserve the plan design and to stay competitive. And our rates are in the mix. Some of our rates are less than the GIC. So I think we are in an incredible position where we are right now. And when we talk about the trust fund balance, saying we need a policy to restrict how much we can put in there. When we build that trust, we are planning for the days when we are not running well. So sure, if there are some things we can do to level some budgets and do some things, but to actually limit that trust balance and not have the ability to really build it up, because when Westford runs bad, we run bad. And so if that trust is appropriately funded, the town will have those monies to level out that spending and that budget in the years that we're not running well. So it's there are so many different pots, so many different levers in all of this. And every if you touch one thing, it's an unintended consequence on something else. But I guess I'm really struggling with how we are having so much emphasis on plan design change at this point, where we have the GLP-1s coming off that are literally going to give $1 million of relief to premium right there. And then having that $950,000, having that be able to go back to the town. That is an incredible benefit to the budget at this point in time. And I'm so careful of what we do with benefits and how we handle them. Because when you give away your plan design changes and you don't get the most money or the most bang for your buck, you are setting yourself up for not having those in the future when you do need them. Because we are not going to run well again. There's no way we're not going to. So having that trust as healthy as possible, we actually could set ourselves up so we could weather the storm. And then when we get back on, we're about a 7-year cycle. But when we can weather that and then get back, we're running well. So it's just, my hope is we can let the trust do what it's supposed to do, and take advantage of us running so well right now so we can be properly funded, and acknowledge that what the trust has already been able to do has really to provide a lot of benefit to the budget where we stand right now, because we could be in a lot more trouble. And Mark can speak to it. The renewal that we're looking at coming up we're looking at a fantastic renewal, which again is relief to the budget. So I worry about touching any of this at the point in time. And I feel like we're incredibly fortunate to have some levers like the 950 coming out and the GL1s dropping off. But I just have such extreme fears, and I just want to have us to be very cautious in how we handle this and to be extremely thoughtful, because if we disrupt this, we won't be able to fix it. We're going to be stuck on a path I don't think that will benefit the town, the employees, and the retirees.
Thanks, Pam. Does anybody else on the trust have anything they want to add before we go to some of the questions in the chat? Okay.
I just had, sorry, Kristen, just
Go ahead,
one
Jesse.
thing. It's not really on this plan design. I promised I had someone new to insurance asking me a question. I promised I'd ask the question because I had never really thought about it. And I thought it was actually a really good question she had. So, and it's probably to Mark. Mark, I should have asked it earlier in the meeting when, you were giving the presentation on the high claimants.
Yeah.
Do we ever look at, and I know we've talked about it as a trust many times, and with, many new people watching, go check out the resources. There's a lot of good wellness things like that. We always talk about, the cost, the expenses, because, that's what we're paying. But is there a way to figure out things that we're doing well through wellness programs, things like that are more like cost avoidance, or things we could do better in that regard? Like, people are getting screenings, so we see, breast cancer rates going down, things like that. I know with like the inflationary and medical, and she knew that too. It's maybe not possible because health expenses just are increasing. But I thought it was a good question because it's a different way to look at it. Like, what are we doing well, and could we do other things so that our expenses could decrease?
Yeah, it's a great question. We engage. So Hub has a health and wellness department. That's all they do. They don't do insurance. They do health and wellness promotion. So they work with various groups to help determine, what programs would be most fitting for your organization based on your claim patterns, based on kind of the makeup of your group, from a professional standpoint. A manufacturer might be different than a law firm, than a town, than a college. So we do have programs that you can put in place, and Hub has, as far as guidance, there's no fees or whatsoever to go through it, and that's all this department does. I think in the past, Westford has done some wellness engagement, and everywhere from doing a pretty lucrative fitness reimbursement, Weight Watchers reimbursement, but there could be other levers you can pull. Nothing that's going to have immediate savings, other than claim scrutiny like we did with that individual, and helped them get out of the hospital setting, saved over $1 million of claims every year by moving it over to the pharmacy. So, I mean, those are the big heavy hitters that we monitor the claims and try to fix immediately, those acute situations. But health and performance or wellness, it's a long-term investment. So it's, there's a couple of schools of thought. Some employers are very invested in it to try to get their employees to be healthy. And you got on the other end of the spectrum, you got employers that say, I have no chance of impacting my employees' health education. Like, all the tools are out there. We all have Google, we all have AI, we all have YouTube. There's 1,000 opportunities to teach ourselves on how to live more healthy lives. And some employers will say, I'm not doing that. That's on the employee to figure out, even if, whatever involvement they can give would help curtail future claims. So I would encourage you to maybe have a meeting. We can invite them to a trust meeting and they could do a presentation. They could do an analysis of your claims and give you some ideas of what programs I think might work.
Yeah, thanks. Thanks.
Sean, go ahead.
Can I offer something really quickly? Sorry. So Blue Cross does allow the town, they give $5,000, which Pam uses every year to kind of schedule some wellness activities or some education. We also put into place Smart Shopper to kind of reward employees when they pick a lower cost, to get their mammogram or their colonoscopy and those kind of wellness things. So the town is working on wellness and trying to put those into place to get a super robust wellness program is an investment on behalf of the trust of, 6 figures at least to try to come up with vendors to help it, because we all know rewards kind of dictate behavior sometimes, at least to get it started. But I just wanted to throw that out there.
Great. Sean?
Yeah, and one of the things that I didn't hear Mark just address, or Kathy addressed just now, is one of the things that can change behavior is deductibles and copays. Like, that's the idea behind, if you have an emergency room visit copay of $1,000, it's to encourage you to go to your primary care for a strep throat swab. It's certainly if your leg's falling off, right? That's different. But there are people who show up at the emergency room for things that are more appropriate for their primary care. And there are mechanisms like that you can use to influence behavior, which can lower costs, which is one of our end goals, right?
Yep, absolutely.
So Pam, I know you have your hand raised. I'm going to wait in a minute. I'm going to take a few of the Q&A, and then if you're a member of the public and don't already have your hand raised, please raise your hand if you have a question, and we'll alternate. Dan or Pam, I may need your help unmuting when I call the name. So just bear with me while I try to do this. We had an anonymous attendee say, what's the benchmark for employer contribution? So I think the question is it 65-35? Is it 80-20? So I don't think that there's a benchmark, Mark, but with your experience, can you try to answer that?
Yeah, I actually did. I benchmarked about 200 communities in Massachusetts. So I could compare what the contribution levels are, varying based on a single rate and a family rate. If you bear with me 1 second, I already did the calculations on those. Bear with me 1 second. I can give it to you off of memory, but I'd rather be more accurate. And I can share this benchmark report with everybody as well.
Still about 75%, huh, Mark?
Yeah, I was surprised. I mean, at least at the communities I looked at, it was a little bit lower on the single, and even a little bit lower on the family. It was about 71.9% on the single. That's employer contribution. And then on family, this includes not just the market basket groups, but many other groups too. I could do it just for the market
But
basket.
is that private sector, Mark, or only municipality?
No, only municipal.
Okay, thank you, Mark.
You're welcome. Family was about 70%.
Okay, thank you. Christina Green asks, as I understand the locked-in report, the estimate of savings going with the benchmark plan within the health insurance trust is 500,000. Is this the equivalent to Hub scenario number 5? And if so, why such a large difference in the estimates?
I can't speak for the locked-in report, but our actuarial formulas are tried and true to determine what, that was leaving the enrollment exactly as it is now in the four different plans that you offer, and then putting in the higher copays and deductibles. I don't know if maybe locked-in used lower copays and deductibles. I used copays and deductibles that were more equivalent with the benchmark plan.
Okay, Christina, if you're still on and want to give me a call, or I can give you a call, we can try to talk this a little bit more and I can try to get you an answer. Ray Dick, the health director, asked, does the GIC offer behavioral or mental health services or options? Many of our town staff families depend on these services for their families and children. I think this is covered in the locked-in report that the services are more limited than what we have now. But Mark, if you could speak to that, that would be helpful as well.
Sure. That usually when we move clients from one carrier to another all the time. The two biggest pain points are behavioral health. So, we say provider networks usually are about a 95% match. That's whether you go from Harvard to Blue Cross to formerly Tufts, Cigna, Aetna, United Healthcare, all around, 95% match on average. Sometimes we see as low as 92, sometimes high as 96. Behavioral health is not nearly that percent match. So that's usually the biggest pain point. As we move a group, a lot of people have to find new behavioral health providers. So I don't know, Kathy, if you could weigh in what the typical match is. If I were shooting from the hip, I'd say about 50%, 50 to 60%.
Yeah, I don't really have a typical match, but it depends where they're going. But there is definitely a difference. And as we all know, it's very difficult to get an appointment even with mental health. So a lot of that depends on the teledoc services as well.
And then I think it exacerbates it because about 20% of your membership is in out of state, primarily New Hampshire, but several others out of state. And that does complex the issue a little bit.
Great. So I'm going to switch over to attendees with their hands raised and then go back to the Q&A. So Dan or Pam, I'm not sure who has the unmuting, but if you can unmute George Ross, which I believe is Jody Ross.
That should be all set. It's taking a minute for it to remote. She's looking okay on my end.
Jody, can you hear us?
Yes. Can you hear me now?
Yes.
Okay. I apologize. I'm on a borrowed computer, but one thing that I just wanted to mention, but I didn't realize you weren't allowing comments until now. So I was going to ask this about 40 minutes ago, but number 2 on the select board's list of what they were asking for was benchmark Westford against comparable municipalities. And I did hear Mark talk about the contribution rate just recently, but I know that was a broad across, the state, not necessarily just our market basket communities. But I think, to me, before we start delving into plan design change options and all that, we would start with the benchmark, because I heard the board say very clearly the other night that they want to remain competitive with our market basket community. And honestly, I don't know, because I've been retired for a few years. I have no idea if our plan is similar to what those other towns offer their employees. And then, of course, the contribution rate is part of that. So that to me is really important to understand, not just the select board asks, but also for the trust and for our employees. If we have a plan that's far more generous than those other comparable communities, then that makes sense to take a look at these things. But if we're already not giving what other communities are, I think that's something that we need to understand. The other thing is, I know Ellen Rainville did send an email in that is on the website, and she asked, when we're looking at our comparison to benchmark communities, to also look at dental, vision. She didn't mention, but I would include life insurance and disability insurance, because all those, other than I think a $1,000 life insurance policy, are not paid or contributed to by the town. So I think that is important just to understand that before we start delving into what plan design changes we want to make. So thank you very much.
Thanks, Jody. I think Ellen also does have her hand raised. Pam, if you could unmute her, please.
Thank you. Well, I didn't realize actually that I was on the website, and I guess I don't have visual, but so I would really strongly be in favor of asking the Health Insurance Trust to take the immediate steps that have been identified in this meeting. One, splitting a transfer back to the general fund of the $950,000 transfer that was made to the trust, with one payment in late June after the June 23rd select board meeting and a second payment in early July. And as of July 1, we would be seeing the impact of the GLP-1 drugs coming off of the plan. And those two things would help mediate the budget impact immediately. But I would like really for us to buy time so that we can, with due diligence, conscientiously look at what I considered an extremely dense amount of information on the Lockton report and the Hub report. And I watched the tri-board meeting, and I read the report 2 times, and I still have questions. I would really request that we resurvey staff. Certainly in my department, I've had significant turnover, but because of retirement, and the people that answered the survey in 2025 are no longer employees, they are now retirees. And I would like to request, as our retired treasurer collector did on Tuesday night at the select board meeting, and as Jody just alluded to, please don't just do a benchmark comparison of premiums, but also identify any other health benefits that towns are paying, so that we really get a comprehensive sense of how our community compares. And I'd also like to ask that we know the percentage that each community spends on health insurance, because I think that will change. And I would like to have that comparative data. Also, I would like to have identified, and the Lockton report did not do this, if we take a high outlier off of a survey and the low outlier off, I would like that community to be identified and the type of health insurance that they're paying for, because that is data that we really need to access. So again, to summarize, I would ask you to take the immediate beneficial steps that don't have an impact on our employees and retirees, especially our non-resident employees, and take the time that this really deserves to come up with a studied consideration of the best options that's both best for the town, and every town department head who's done budgets for decades knows the challenges of the budget, but what's best for the town and what's also best for our workforce, both current and retired. Thank you.
Thanks, Ellen. I'm going to go back to the questions, and I know Ellen had submitted those requests in writing as well. Hi, Mary. And we can see what Sean thinks about that related to select board of the feedback and what the trust thinks as well. So just moving on, This is from an anonymous poster. If we were forced into a GIC/plan design changes, would the town be open to increasing their contribution to 80% to offset the cost shifted to the employee? I will answer that directly. This is what the analysis we need to do related to if we were moved to the GIC or other plan changes, what an increase or a decrease in contribution rates would do to the premiums and the budget. So we cannot make that answer today, but that would be reviewed as part of this process. And then Tyler Butts asks, are we aware of Maura Healy stating in February of 2026 that there will be a budget cut to the GIC of $100 million? I haven't followed the news closely. Mark, I don't know from your expert advice if there's anything you want to share.
Sure. Yeah, I think from the plan changes, probably mostly the elimination of the GLP, that was $100 million less that they expected to spend, but it doesn't. It didn't count for the rest of the inflation, medical and prescription inflation, which continues to go up, and that's why they did have a rate increase this year. I'm trying to think of every averaged around an 8.5% rate increase across all their plans. But also, they were still, in April, they had to come up with another $340 million just so they could keep paying their claims. So being in this business as long as I have and knowing how big the GIC group is, it's very easy I don't even have to look at the claim reports and I can predict their future. I just know how claims trend, and there's such a big group, you can't avoid trend. There's nothing it doesn't matter how big the group is. Cancer costs the same if you're on a GIC plan as you are on a Westford plan or any Amazon plan. It doesn't matter. So I think their costs will continue to go up. I'm guessing that $100 million, I'll look it up, but I think it was probably mostly pointing to, we would have had a bigger increase, but we were able to cut $100 million out of the increase due to the elimination of the GLP weight loss drugs.
Thanks, Mark. And then the last question I see on the Q&A is from Diane Wood. I think this happened at a particular point in the meeting where she posted this. I feel that as though I'm listening to a campaign debate. Our trust members should be neutral in ensuring all facts and data are available and without bias. So we'll take that, Diane. Thank you very much. Let me just close the Q&A. I'm not seeing any other hands in the attendees at this point in time. So I want to move to kind of the next phase of the meeting where I think we've summarized what we may be able to get to the select board for the 23rd meeting. Sean, I'd love to just get your input of, are we framing this properly to present to the select board? Is there anything we're missing? And then get to the next phase of, do we need to meet as a trust before the 23rd? We know that we'll need to meet after the 23rd to talk about the $950,000. So just trying to wrap up those items at this point in time.
Yeah, from my perspective, I think the discussion on the transfer of the $950,000, right, that takes care of one of the issues. It seems like everyone's in consensus that the GLP-1s that has to come off. Which is some immediate savings. The tougher nut to crack is plan design changes, at least from my perspective. And I think that the trust is going to need some time, and I appreciate Pam's thoughtful remarks. That's something that has to be done. There has to with patience, right? And so there's an opportunity for everyone to weigh in, and we need more information. And it sounds like a lot of the members of the public have asked for more information, particularly where do our premiums and our everything else that's offered, where does that land relative to other surrounding communities? And once we have that information, I think the select board would be able to make a decision on that. But certainly, I think this group probably needs some time. I don't think that the trust will need to meet again before the 23rd. I'm okay referring back to my partners that's being looked into, and at some point the health insurance trust will, give some more options, or whether or not plan design change is something that this group's even recommending, right? So. So yes to the yes to the 950, yes to the GLP-1 taking off, table the issues for stop loss and for plan design changes. Is that
So I wouldn't say table, right? I would say continue to explore
exactly? Thank you.
those when the time. Okay.
Yeah, not to be. So if this group feels like they can make a decision on that before the 23rd, great. If not, then I think I'm okay going back to my colleagues and saying that the trust needs more time before they report back on those issues, which are plan design changes and stop loss changes.
Yeah, I think we'll do our best to get what data we can. I think it's important to get the data correct, both with the locked-in report and now Hub digging in. So we're committed to getting as much information as we can to the select board in advance of their meeting. You know, it's not the 23rd is the meeting date. I want to make sure that they have adequate time to review what we talked about this. So the packet will go out on the 18th in advance of that. Anyone else from the trust want to add anything to our discussion today?
Just one final, really hopefully quick comment. Something to think about. I'm sure Dan, he maybe even knows the number. Dan, do you know how much we, essentially could return this year if we had to without jeopardizing that 65-35 split? The only thing, and I don't know if it matters to anyone, but so if we return it in June, it'll be available for FY27. The other half of that, though, wouldn't be certified again until FY28. So I just want to, if that's a concern or something to think about, it's a logistics thing for just to know about at least, because if we don't close it until FY27, free cash won't get certified until the following year. So we'd be looking at over a year away. So just wanted to throw that out there.
So I think that's okay, Jesse, because FY28 is when we have our budget issue at that point. So even if we have half and half, we can still earmark it, track it, and use it for the purpose
Okay,
that,
great.
we decide. I haven't run the numbers yet on whether or not we'll break even with the 475, but that's definitely I can do that for the select board meeting.
Great, thanks for that addition. Okay, so looking at calendars for the next time this group can meet to make that final decision and to reflect on anything else that the select board talks about on the 23rd. What is this group's I know we generally meet. Christine, you have the time constraint due to school. I know Nate had to drop off and Hannah is driving, so I'd want to check these dates with them as well. Christine, is 3 o'clock usually too early, or is that time appropriate for
I
you?
can make 3 o'clock work.
Okay, so I think we'd look at the 24th, the 25th, or Dan, is the 29th too late?
Yes, the earlier the better. If we're primarily focusing on just a transfer, even the 24th would work. Just give us a little bit of time to get that going.
Okay,
And
so
If it's not a long meeting, yeah.
I'm out of school on the 24th and the 25th. So if earlier is easier for everybody, that's a possibility.
okay, so Pam, if you could poll everyone tomorrow for either of those dates, that would be great.
Okay.
All right, is there anything else before the trust?
There's one more
Oh, there's
comment
one more
out there.
question. Thank you, Dan. So is the trust and select board prepared to miss the July deadline if there is a major disagreement? I'm not quite sure how to answer that. Sean, would you like to?
Yeah, I believe that
that?
was a reference to the GIC deadline, which is a notice that is sent to the state of, I guess, a plan to keep them to pursue the GIC, right? It's not an application, but just a notice to them. I mean, I feel like I have enough to make a decision as to what's in the town and employees' best interest right now. I can't speak for my colleagues, so but
I think we
I
have
feel
to see what
prepared.
happens
Yeah.
on the 23rd, and then we have our meeting on the 24th. And if we need to call a special meeting of the select board, we have done that in the past for emergency type of things. So we would be prepared to do that. I know that may not give employees certainty or uncertainty, so I apologize for that, but this is the best we can do right now with the information that we have. All right, so with that, we will meet again on the 24th or 25th, time to be determined. Pam will send that and circulate that out. Like I said before, we're looking to post this meeting on our website, hopefully tomorrow, for those who would like to view it again. And if you could all be prepared, if you can, to come to the select board meeting on the 23rd. I have this matter fairly close to the front of the agenda, as there's some other matters towards the end of the agenda. I'll post that as a joint meeting as well. If there's something we need to meet about, on the 23rd at 6:30 or 6 o'clock, we may ask for that. All right. So with that, I will take a motion to adjourn.
I'll second.
Is there I don't want to make the motion. Does anybody make the motion?
I can. Motion to adjourn.
And Christine seconds. So I'll just do a roll call to get us out. So Christine?
Yes.
Sean?
Aye.
Pam?
Yes.
I think Hannah's driving and I'm an aye, so that's a quorum. Thank you very much, everyone.
Thank you.
Bye, everyone.
Thank you.
Thank you.
Thank you very much.